PRAGUE-17 was a prospective multi-center randomized trial conducted as non-inferiority trial, and the goal was to compare two treatment strategies for patients with atrial fibrillation. The first one was a treatment by NOAC, and the second one the left atrial appendage occlusion. We focused on high-risk AF patients, and therefore we included patients with atrial fibrillation and one of the following: history of cardioembolic event, or history of bleeding, or patients with high Charles-Vask and Hasblad score. It means Charles-Vask had to be greater than 3 and Hasblad greater than 2. The primary endpoint was a composite to encompass both benefits and risk associated with both these different treatment strategies. It means it was a composite of stroke, OTIA, cardioembolic event, significant bleeding, cardiovascular death, and procedure or device-related complications. The bleeding was defined according to the definition of the International Society on Thrombosis and Hemostasis as the major and non-major bleeding. The non-major bleeding was all bleedings that required hospitalization or invasive procedure. The study started in October 2015, and 402 patients entered into intention to treat analysis. Originally 415 patients were randomized, but 13 had to be excluded due to decline in informed consent and due to finding of thrombus in the appendage. So 402 patients entered into the analysis, 201 patients in each arm. And in the appendage closure group, the success rate of the procedure was 97% if it's calculated of the procedural attempts, or 90% if it's calculated of the entire number of patients in the cohort. Regarding the NOAC arm, the most often used agent was apixaban in almost 97% of patients. Regarding the results, the incidence of primary endpoint was similar in both groups, and it reached almost 11% in the appendage closure group and 13.4% in the NOAC group, and that means that appendage closure was found to be non-inferior to NOAC treatment. P-value for non-inferiority was very low, it was 0.004. The results were very consistent in per protocol and on treatment analysis, and if you look at the secondary endpoints, the rate of stroke was also similar in both groups, and it reached about 2.6% per year. Cardiovascular death was also similar, and the rate of bleeding were also similar, surprisingly, because 6 of bleedings occurred as procedural device-related complications. We analyzed also the non-procedural bleeding that were slightly less in the appendage closure arm, but this difference did not meet statistical significance. So we concluded for patients who are looking for non-pharmacological strategy for a stroke prevention atrial fibrillation, appendage occlusion can be offered as a treatment strategy with equal outcomes as the NOAC strategy. Definitely a larger study with endpoint of cardioembolic event only would be nicer and better to persuade the scientific community that appendage closure works in similar way as the NOAC group, but unfortunately no such is underway, and because there is no big support from industry, I don't believe in next few years such a study will be started.